Welcome to Critical Conversations, the podcast where we explore cutting-edge developments in professional education. Today, we're diving into a topic central to medical practice, clinical reasoning. Our discussion draws from the insightful book, Principles and Practice of Case-Based Clinical Reasoning Education, a method for preclinical students, edited by Olaten Kate, Eugene J.F.M. Custers, and Stephen J. Durning, with contributions from Judith L. Bowen, Guyanne Simonia, Angela Van Zyl, and Maria Van Loon. This work tackles a critical challenge. How do we effectively teach medical students to think like doctors even before they enter the demanding clinical environment? Let's start by defining what clinical reasoning actually is. At its core, it's the mental process that unfolds when a doctor encounters a patient and needs to draw conclusions about the patient's complaints, potential causes, likely diagnoses, and the appropriate management plan. It's often a complex, even obscure process, varying from quick, intuitive judgments to painstaking, deliberate analysis over days or weeks. The authors explain this through the dual process theory, categorizing thinking into two main systems. System 1 thinking is rapid, requires little mental effort, and is often called pattern recognition. Think of an experienced doctor instantly recognizing a common illness. This relies on a vast mental library of illness scripts, mental representations of diseases that combine enabling conditions, underlying pathology, and expected signs and symptoms. System 2 thinking, on the other hand, is analytical, slow, and effortful. It's used when System 1 doesn't provide a clear path forward, often involving a causes and effects reasoning process, much like what medical textbooks describe. Both systems are vital in practice, often working on a cognitive continuum. However, clinical reasoning isn't without its pitfalls. Errors can arise from a lack of knowledge, faulty data gathering, incorrect interpretation of tests, or cognitive biases like anchoring bias, sticking too closely to an initial thought, or premature closure, stopping the diagnostic search too soon. The goal of effective education is to minimize these errors. Now let's trace the historical journey of teaching clinical reasoning. In the Hippocratic era, it was about careful observation and aphorisms, if-then rules based on experience. Figures like Battista de Monte and Hermann Barhow introduced early forms of bedside teaching. But it was Thomas Bond in 1766 who brought empirical rigor by correlating clinical predictions with autopsy findings, opening the door to improving diagnostic reasoning through observation. William Osler further refined this with his emphasis on differential diagnosis in the late 19th century, recognizing that similar symptoms could stem from different diseases. Abraham Flexner, in his influential 1910 report, pushed for a scientific approach to clinical medicine, viewing the clinic as a laboratory. However, his vision often clashed with the realities of medical practice, where intelligent guesswork and tentative interpretations are sometimes necessary. Fast forward to the mid-20th century, and the rise of diagnostic tools like the logoscope and early computer-assisted instruction attempted to mechanize diagnosis. But these early systems, along with problem-based learning, or PBL, initially overemphasized a general problem-solving ability, believing a generic method could be taught independent of specific medical content. A pivotal shift came with the groundbreaking work of Elstein and colleagues in 1978. Their research showed that expertise in clinical reasoning wasn't a generic skill, but deeply dependent on a vast and well-structured knowledge base acquired through experience. Experts weren't necessarily better at the process of reasoning, but rather generated more promising hypotheses early on, highlighting the crucial role of content-specific knowledge. This moved the field away from simply trying to teach a generic problem-solving algorithm. This brings us to modern conceptualizations of clinical reasoning. It's seen as both a process and an outcome, involving cognitive operations to gather and analyze information and decisions that account for patient circumstances. The reasoning process itself can be deconstructed into abstraction, abduction, deduction, and induction. Knowledge is represented mentally through prototypes, instances, or semantic networks. A key concept here is semantic qualifiers, which are abstract terms used to organize patient information, like acute monoarticular arthritis. These qualifiers help clinicians activate illness scripts, which, as mentioned, are high-level mental structures connecting enabling conditions, pathology, consequences, and management options. With experience, these scripts become more elaborate, allowing for rapid pattern recognition, often referred to as encapsulation of knowledge. Interestingly, the intermediate effect suggests that very experienced clinicians sometimes recall fewer details than less experienced ones, because their knowledge is so highly condensed. The dual process theory is revisited, emphasizing that System 1 and System 2 thinking often occur simultaneously, forming a continuum. Performance is also highly case-specific and context-specific, meaning a doctor's ability can vary significantly depending on the particular patient and the environment. Developing expertise in reasoning, much like in other domains, requires deliberate practice and reflection, as highlighted by scholars like Schoen and Mehmed. Ultimately, many diagnostic errors stem not from flawed reasoning processes, but from insufficient knowledge. So, how do we teach this complex skill to junior students? The authors propose 6 prerequisites for learning clinical reasoning that should be fostered in preclinical education. First, clinical vocabulary. Students need to learn to talk like a physician, using medical terminology and semantic qualifiers to accurately describe symptoms. This allows for clear, efficient communication within the medical community. Second, problem representation. Students must learn to transform a patient's story into a structured, conceptual description of the problem using those semantic qualifiers. This critical step triggers the activation of relevant medical knowledge. Third, illness script mental repository. Through exposure to many cases, students build an internal library of illness scripts, mental schemas of diseases. This framework helps them organize and recall information efficiently. Fourth, contrastive learning. Students are encouraged to explicitly compare and contrast diagnostic hypotheses, identifying similarities and differences between plausible conditions. For example, distinguishing between osteoarthritis and rheumatoid arthritis. Fifth, hypothesis-driven inquiry. Rather than a rote head-to-toe exam, students learn to ask specific questions and perform targeted physical exam maneuvers that help discriminate between their leading hypotheses. And finally, diagnostic verification. Students must develop the habit of following up to confirm diagnoses, reflecting on the outcome to enrich their illness scripts for future encounters. The case-based clinical reasoning, or CBCR method, is specifically designed to address all these prerequisites, preparing students for the complexities of real patient care. Now, let's explore how the CBCR method operates in practice. CBCR takes place in small groups, typically 10 to 13 students. Sessions are usually scheduled every 3 to 4 weeks over a prolonged period, ensuring a longitudinal approach. Rooms are arranged to facilitate interaction, often with a blackboard or flip chart for collaborative reasoning. Consultants, clinical teachers, are present, but their role is truly consultative, stepping in only when needed. The source notes that the optimal group size is often cited as 10 to 12 students. The materials are structured into 3 versions: a student version with basic case information and objectives, a peer-teacher version with hints and additional information, and a consultant version with all answers and background details. This graduated information flow is key. A typical session lasts about 2 hours. 3 students rotate as peer teachers, leading the discussion, providing information, and even delivering short mini-lectures on relevant topics. All students are expected to prepare the initial case questions, fostering active participation and verbalizing their thought processes. The peer teachers guide the group through the case, often using tables on a board to contrast diagnostic hypotheses against findings. This structured approach helps students systematically build their clinical reasoning skills. The consultant, meanwhile, observes, offers guidance, and provides feedback, ensuring the learning process is effective. A notable adaptation seen at UMC Utrecht involves senior medical students acting as near-peer consultants, which has proven highly successful in both teaching and learning. Case quality is paramount in CBCR. Cases should be relevant, realistic, engaging, challenging, and instructional. For preclinical students, a focus on typical or prototypical cases helps build strong foundational illness script rather than immediately tackling rare or complex presentations. Cases are designed to mirror real patient encounters, progressing from initial presentation through history, physical exam, diagnostic tests, and management plans. They also include optional scenarios to explore alternative diagnostic paths. The book emphasizes that cases should be authentic reflections of what students will face. Assessment is a powerful driver of learning, and the CBCR method incorporates a specific test developed at the University Medical Center Utrecht. This electronic, case-based test is designed to closely align with the cases discussed in the course, reinforcing the learned illness scripts and patient-oriented thinking. It features relatively long lists of options for diagnoses, history questions, exam findings, and management, often including sequential scenarios that alter the patient's presentation to assess adaptive reasoning. The test has demonstrated good reliability, providing a robust measure of students developing clinical reasoning abilities. Furthermore, the assessment should ideally cover the range of cognitive operations, abstraction, abduction, deduction, and induction, used during the CBCR sessions. Finally, integrating CBCR into a curriculum requires careful curriculum development and faculty development. As the authors note, curriculum isn't just a planned document, it's also delivered, experienced, and even hidden. Implementing CBCR can serve as a first step towards broader curriculum modernization, embracing elements like student-centered, problem-based, and integrated learning. Faculty or consultants need specific training for CBCR, including written instructions, workshops on case writing, and practical sessions that demonstrate effective group facilitation. The time-in, time-out method, where observers can pause a session to discuss teaching strategies, is particularly effective. Students also need to be trained for their active roles, especially as peer teachers, to foster a new mindset of collaborative learning and open discussion. A successful example is the introduction of CBCR at Tbilisi State Medical University in Georgia, which demonstrated high satisfaction among both faculty and students, leading to its compulsory inclusion in their curriculum. In conclusion, the case-based clinical reasoning method, as detailed in Principles and Practice of Case-Based Clinical Reasoning Education, offers a robust and well-structured approach to teaching this indispensable skill. By focusing on essential prerequisites, fostering active learning, and aligning assessment with clear objectives, CBCR effectively prepares preclinical medical students to think like a doctor. Our gratitude goes to Ola Tenkate, Eugene J.F.M. Custers, Stephen J. Durning, and their fellow contributors for sharing these valuable insights. Join us next time for another critical conversation.